We starting? Hello. Good evening, everybody, and a happy new year. Hello, Midhun sir. Good evening.
Good evening and Happy New Year to everyone.
So we just had NEET SS critical care, and this is a recall session based upon all the recalls that we have uh, collected. We have collected based upon that. This recall session will be there. So you to understand that this is a recall session and there are certain disclosures attached with it because it's a recall session. It cannot, I cannot, like, we cannot guarantee, 100% accuracy. Some options were not recalled by people. The images given obviously are for representative purposes only because they were fetched from the internet and not exactly from the question paper. Right, sir? Anything to add?
No, and I'm actually extremely grateful to Manish for compiling all the almost all, we got. I think we got almost
Yes,
150
sir. I mean,
questions, and
yeah,
extremely
maybe
grateful
two, three
to the
questions.
students also. Yeah,
Yeah.
who have helped us to combine all the questions together.
Yes.
A lot
Thank you
of
very
people
much.
have contributed to this.
Thank you, everybody, for your contribution. With that, we were able to compile the questions and let's see what were the questions and let's discuss. So we will basically, go through all of these questions very swiftly. We won't be going into a lot of details about the topic. We'll just give you an idea so that you can understand where you are standing in terms of what you had marked and all that. So it is it is about that. We will touch upon the topic here and there, but not a complete detailed analysis. Okay. Yes, sir. So let's start with question number one, which a lot of people had recalled this question, that there was an image of an airway device, which was asked which device is it, right? So this is basically suffer device, which was given in the question, which was given in the examination, and it was about it is basically a mouth-to-mouth device which was invented by Dr. Peter Suffer. Okay, so he's believed as father of cardiopulmonary or CPR, basically, right? He is the father of CPR. So he made this device in around 1958, along with somebody who was a fireman. So they used it to give mouth to mouth and mouth to mouth, resuscitation or respiration. So this was the device which was asked, and they made it in obviously steel, and this is like a plastic remolding of the device, basically. Anything?
No, let's continue. Let's continue.
Okay. So question two was BLS. In BLS, after scene safety, what is next? And some of the people have recalled the options as it was check responsiveness, start compression, or call for help. So BLS is a very rigid algorithm, like a very algorithmic approach to cardiopulmonary resuscitation, right, or CPR. So you have to follow those protocols very algorithmically and very systematically. So after scene safety, like in this, you can see after scene safety, you have to check for responsiveness. Okay, so the correct answer here becomes check for responsiveness. Okay, right. So the correct answer was A, check for responsiveness. Okay. So, question three was depth of chest compression during CPR. And some of the people had recalled option as at least 1.5 inches, at least 2 inches, or at least 2.5 inches. So this here, they basically, try to confuse you. Uh, so the depth of CPR mentioned or chest compression mentioned is 5 to 6 centimeter, right? Which is 2 to 2, maximum is 2.5 inch, not at least 2.5 inch. The correct answer here will be B, at least 2 inches. Okay, so you have to maintain your chest compression depth, and the maximum you can go is 6 centimeter, not at least. If you are going at least, then there is more chances of causing injury. So you have to keep that in mind. So the correct answer here will be B, at least 2 inches. Okay. Question number 4 is number of breaths given in 1 minute according to ACLS protocol, and people recalled A 10, B 15, C 20, and D 30. So the correct answer is, every 6 seconds if you're giving, so it comes to around 10 breaths. Okay, so 10 breaths is the correct answer. I think it was asked last year also, this similar kind of a question where they had asked, number of breaths in a minute. So what I'm seeing is a lot of questions like Makocha score and all of that were repeated from the last year. So it is there are certain it is coming it is turning out that certain topics are favorite of the examiners and they will continue to ask from those topics. So it is imperative that if you are revising or reading for the next session, that you you should go through these recalls and these topics which have been asked earlier, and should uh, try to remember them, or try to at least revise them before you go for the examination. So the correct answer is 10. Okay. So this is basically the your CPR algorithm. So we had already discussed all of those things, so I'm not going to delve into that further. Okay, so question 5 was there, that patient is choking and becomes unresponsive while performing Heimlich maneuver. So what is the next step? So whenever somebody becomes unresponsive or goes into cardiac arrest due to hypoxia because of the choking, the next best step is to start CPR immediately. Okay. So whenever the patient becomes unconscious during Heimlich maneuver or without Heimlich maneuver, while they were choking or when they were choking, the thing is to start chest compression, because ultimately chest compression will also generate the kind of force that is required to push the foreign body out. Okay, so you have to continue and you have to check if you see it on the mouth while giving rescue breaths, then you have to check if you can see it and you remove it. Blind sweeping is not advised anytime. So the best step is to start CPR. Okay, so anything to add anywhere?
Just remember that the new guidelines have been produced, and in that, instead of the Heimlich maneuver, now the first step is to give back blows even in adults. So this is based on the 2020
2020 guidelines.
AHA guidelines. Yes.
Okay. So, and the question some people had recalled, it was about Makoka score, and some people were like, they had asked which was the highest variable point, or which had the lowest variable, which variable had the lowest point, or which variable had the highest point. So I wasn't very sure what was the question. So I have added the image of Makocha score basically for difficult, for expecting difficult intubation, so difficult airway. So, the highest point is given to Mallampatti 3 or 4, and the lowest point is given to a lot of things like non-anesthetist intubator, or hypoxemia or coma or mouth opening less than 3, or cervical spine limited. So I think because there are so many variables for lowest points, I think the question would have been which variable has the highest points, I think. So that would have been Mallampatti 3 or 4. Okay. So that is your Makocha score. You should revise it because it was asked last year also, Makocha score. Question 7 was some people had sort of similar question they had recalled, that there was cannot intubate, cannot ventilate kind of a scenario. Some people had said that it was just cannot intubate. Some people had said no, it was both cannot intubate, cannot ventilate kind of a scenario. So whenever so I have like I will go discuss a little bit about it. So Cormac Lyane grade 4, right? Two failed intubation attempts were made, and BMV also was difficult. Bagmos ventilation was also difficult. So what is the next step? So this is a failed intubation and failed ventilation also, because BMV has also failed. So whenever that is there, you have to directly go for front of neck airway. But whenever it is failed intubation attempt, you can go for airway adjuncts, like according to, there are multiple difficult intubation or difficult airway management algorithms, but usually, so everywhere you will see that airway adjuncts are preferred, especially the newer airway adjuncts are preferred, LMA, iGel or something like that. So if you can put it, then, and if you can ventilate it with that, then fine. If you cannot do that also, then you go for front of neck airway or cricothyrotomy or something. Okay. So basically, cannot intubate, cannot ventilate, kind of a scenario. So this was the scenario, and yes, so this here we have front of neck airway. I'm trying to see some of the comments as well. Uh, yeah, so cannot intubate, cannot ventilate scenario only. So yeah, so front of neck airway is the answer there. Okay.
Yeah, for Macoca score, the question, I think it's least, the lowest score.
Okay. So lowest, if the lowest was there, then there are multiple, depending upon what option they have given, you have to correct this
Yes.
right one, because there are multiple options for that, non-anesthetist and a lot of things are there. Okay. Mouth opening, cervical mobility reduction and all of those can be the option. So whichever was there, you have to correct, you have to pick it correctly. So, cardiac arrest in a pregnant patient with two rescuers. Why is the second rescuer needed? So, the answer is, according to the algorithm, you have to provide continuous left lateral uterine displacement. So, the second rescuer is for left lateral uterine displacement whenever you have, cardiac arrest in pregnancy. Okay, so the second rescuer is for that. Okay. So, which drug can be used for bradycardia management once transcutaneous pacing fails? And people have recalled both option as dopamine and epinephrine, and the third option was which was recalled was atropine. So, according to the algorithm gives both, like dopamine and I think I have put the wrong algorithm, but algorithm gives both dopamine and epinephrine as option, but dopamine is always kept on top of epinephrine. So I think dopamine, if both are there, then dopamine should have been the answer. Sir, any inputs?
It's a confusing one. In the AHA, both drugs are there,
Yeah.
but practically the usage of dopamine is very, very less nowadays because of the increased risk of arrhythmias associated with it. And so, especially in US and all, they are using a lot of epinephrine in bradycardia management.
Yeah.
So the answer to that, we cannot say which one is the right one right now.
Because in AHA algorithm, both are there.
Both are there.
So if one of them is given, then obviously the answer becomes that one only. Either dopamine or epinephrine is given, then the answer is either dopamine or epinephrine. But if both are given, then it becomes difficult because AHA gives both. And when you see the algorithm tables, dopamine is written just above epinephrine. So I don't know if that means anything. But both are given equal importance. Question 10 was, what is the definitive way to confirm endotracheal intubation? And people have recalled options as vocal cord visualization, chest rise auscultation, and end-tidal CO2. Okay, so this again, you would think that vocal cord visualization is probably the correct answer, but the correct answer is end-tidal CO2, because there have been, they have been uh, like there have been trials on it. There have been multiple data is there which suggests that EtCO2 is much better than anything else. Ultrasound is becoming, with the bullet sign and all those things, it is becoming very good at predicting correct intubation, but it is still not, the data doesn't suggest that it is as good as EtCO2. So EtCO2, whenever is there in the option, you have to choose EtCO2. And one more thing, so ultrasound, EtCO2, and one more thing is there. Then when you see the vocal cord between, so when you see the tube between vocal cords, then it is another good option. But but just vocal cord visualization cannot be a good option. So whenever EtCO2 is there, always choose EtCO2. EtCO2 is the best option. Okay, so EtCO2 is the correct answer here. Okay. So there was a question about static compliance and dynamic compliance, and they had asked, like, what does it like? I wasn't very sure. People have not recalled the options given, so they just told that okay, there was a question about static and dynamic compliance. Okay, so static and dynamic compliance, the components, so static compliance is tidal volume divided by P plat minus P, and dynamic compliance is tidal volume divided by inspiratory pressure minus P. Okay. So, you have to do inspiratory hold to calculate the static pressure, and dynamic pressure has the component of airway resistance as well. So these are probably, they were asking that if dynamic, compliance has component of airway resistance or not, or probably this was a question about which is lower, which is higher, so that is there. I'm not sure what the question was, but there was a question on static compliance and dynamic compliance, and these are the components. So components of static compliance are basically lung and chest wall elastance, and for dynamic compliance, the components are elastance plus resistance as well. The airway resistance is also is also in there in the dynamic compliance. Okay, anything to add?
No, it's fine.
Okay. Uh, so, question 12. So, A gradient, what causes increase in A gradient, right? So, A gradient is basically, PaO2 minus, alveolar, basically, uh, alveolar arterial gradient, basically, and the formula to normally is a, low, and the formula is age by 4 plus 4. It increases with age, right? And, it is increased in VQ mismatch, right? And shunt, right? It is increased in shunt. So, what was the exact option has not been recalled. So, I will check if somebody has uh, mentioned it in comments.
No one has mentioned
Yeah,
that.
no. Okay. So yeah, and so this there was a question about A gradient, what causes increase. So the probably it was either VQ mismatch or a shunt they would have given as option. Okay, probably one of those two would have been in the option, which would have been the right answer there. So, and there was a question which is basically about best zones, right? But it was probably framed as something which was, that a resident was inserting a PA catheter. And in that PA catheter, he has reached a zone where, the arterial pressure was more than venous pressure, which was more than, alveolar pressure. So this, which zone does it correspond to? So arterial more than venous more than alveolar is basically, like continuous flow kind of a scenario. So continuous flow is seen as in West Zone 3. West Zone 1 is, dead space, basically dead space. So where alveolar pressure is the highest, okay. And then you have the waterfall effect in, West Zone 2. So the West Zone 3 is the correct answer, which basically corresponds to continuous flow. Okay, so continuous flow. And West Zone 3 would have been the correct answer there. Okay. Yeah, so somebody is saying that shunt was the option given there. So I think the shunt would have been the correct, like, option there. And somebody saying that somebody is saying that arterial more than alveolar more than, venous pressure. If that was the scenario, then obviously the answer would be West Zone 2, because it is basically waterfall phenomena is there, right? So intermittent flow will be there. So if that is the scenario, then it becomes West Zone 2. But what I had been given by 2, 3 people, they recalled that it was West Zone 3 kind of a scenario where arterial was more than venous, was more than alveolar. If I can't say what was the question based upon recall only I'm trying to tell you. So there was a question about, there was a PV loop and they had shown beaking in that. So beaking always indicates over distension. Okay, so the answer, correct answer there would have been over distension, right? Some nobody like people had not given me exact options there. Recall in the recall. So I'm assuming over distension would have been one of the option, which would have been the right answer. Question 15. So, which oxygenation device generates PEEP? And there were multiple oxygenation device was sorry. There were multiple oxygenation device were given there, and obviously HFNC or HFNO, right? High flow nasal cannula or high flow nasal oxygenation becomes the correct answer there, because on mouth close it generates a PEEP of around 3 to 5 centimeter of water, right? So with mouth close it can generate a little bit of PEEP. So none of the other devices of oxygenation like NRBM or Venturi or Hudson mask are known to generate PEEP. So the correct answer would have become HFNC. Okay.
Okay. Regarding the pressure volume loop, the question
Yes,
was
sir.
what to do if beaking appears.
Yeah, so you have to either like if it's trapping, or reduce the respiratory rate, or not. If not, then you have to reduce the volume which is being delivered to the lung to prevent the over distension. So depending upon what was there in the answers in the options,
Or
I think.
increase respiratory time.
Yeah, yeah. So there was an ETCO2 graph. Somebody said shark fin, somebody said curare cleft, somebody said there were cardiac oscillations. So I'm not, or increased baseline, somebody had also said. So there are two, three, probably, I don't know if there was only one question or two, three question of capnograph. So the one on the top that you see is shark fin appearance. It basically indicates that you are having spasm, bronchospasm. Right. And the one in the center is curare cleft. When person is waking up from paralysis, or they're trying to breathe, so they will take in some of the breath, right? Some of the flow will be taken off from the ventilator circuit, right? And that will look as a dip during during expiration. So that will come as curare cleft. That is known as curare cleft. Okay. And then cardiac oscillations are also in the end, which is a normal phenomenon which can be seen. The cardiac oscillation can be seen. And there is another thing with increased baseline. So this is basically classically it is taught with the anesthesia circuit, because though your CO2, the your uh, they had the problem with this. You don't really see it in modern day ventilators, but uh, you know uh, if you have a graph like this with a question like this, then you have to tick the answer as rebreathing. Okay, you have to tick the answer as rebreathing. Okay, so
From the comments, it's saying that it was sort of like a match the following question.
I
So
should
all
match the
three
following
graphs.
question. Okay, 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 okay. So yeah, probably all three, four graphs were there, right? Okay. So inverse ratio ventilation, what does it achieve? So normally what we do is we have inspiratory times are shorter than the expiratory time, right? To allow, expiration or exhalation of the gases, right? Because it's a passive phenomena. But in ARDS, in severe ARDS, what we do is we increase the, inspiratory time to allow more time for oxygenation to happen, which basically generates some sort of auto peep, okay, which traps the air and generates some sort of auto peep. And that is the whole logic behind it. And that is what it is used for. It is used to achieve some sort of auto peep to, increase the oxygenation. But nowadays we rarely practice it, because, we have seen with the proning and with the peep, high peep, ventilation, we can achieve most of the benefit which we were achieving earlier with inverse IE ratio. So post in the newer practice, we rarely do it, but yeah, you should know it. So the answer would have been, whatever the option was given related to that, probably auto peep or something like that. Anything to add?
No, it's fine. It's mainly for oxygenation, the
Yeah.
increasing the inspiratory time and increasing the mean airway pressure to increase the oxygenation there.
So there was another question which was given as pH was very low, like 6.9 kind of pH with PCO2 110, 120 in COPD patient. What would have been the management? And probably NIV and ventilation both would have been the option to confuse you, right? So usually everybody, all the COPD patients, all like for hypercapnic respiratory failure, the preferred line of management is non-invasive ventilation, right? Even if they are little bit dull, we prefer non-invasive ventilation, unless only in certain condition when they are peri-arrest, when they're not breathing on their own, or they're very poor sensorium, they're about to dip. Or it has been seen that when the pH is severely low, some places it is mentioned at 7.2. If the pH is severely low, usually NIV trials fail. And if the pH remains 7.2 after 11, 7.25 after a trial of NIV after like a couple of hours, then it is better to intubate them. So if here in this is probably a peri-arrest kind of a situation, then if in invasive ventilation is as an option, then it would have been probably a preferred choice depending upon what the scenario would have been. If the patient was very conscious and stable hemodynamically and all, then maybe depending upon what scenario they give, you can think of NIV. But here, in such scenarios, in severely ill patients who are peri-arrest, dull, then obviously mechanical ventilation, endotracheal intubation, mechanical ventilation, or invasive mechanical ventilation becomes a correct answer. Anything to add?
It's a case of severe respiratory acidosis. I would
Yeah,
go with mechanical
yeah,
ventilation as you
mechanical.
mentioned. Yeah.
Okay. So, so there was some people had recalled two, three kind of a scenario where there was a question about low FEV1 to FEV1 to low FEV1 to FVC ratio or low FVC or something like that. And basically they had given option as COPD, ILD or restrictive. So probably like the answer was COPD here, because whenever there is low FEV1 or FVC. So it is about COPD. It is about obstructive, pathology. So the answer would have been COPD in this scenario. Even if it was low FEV1 or low FVC, both if they had given as low, then also the answer would have been COPD. If they have given FEV1 low with low FEV1 to FVC ratio, then also the answer becomes COPD. Okay. So how to predict NIV failure in neutropenic patient? So before starting, okay. So this was one of the like questions, and the options they had given was outpatient status, disease severity, Apache score, or ECOG score. So here we don't usually prefer non-invasive ventilation for immunocompromised patient or neutropenic patients. Okay, why? Because the cause of respiratory failure in most of these patients is basically some sort of pneumonia, some sort of respiratory pathology, some infiltrates, right? And here it has been seen. Earlier trials had shown that okay, this NIV improves outcome, but recently the data suggests that NIV does not actually improve a lot of outcomes. So here HFNC is actually more preferred, but under certain circumstances like cardiac, there is a component of cardiac failure or fluid overload and all, you can try NIV under supervision. And there have been multiple studies which have shown what predicts NIV failure. One of In most of those studies, disease severity was a common factor which had predicted NIV failure in these patients. So disease severity, in other terms, you have high, Apache score or high SOFA score. So if those are the option, then they become a good choice there. So here, Apache score would have been probably correct answer. Okay. NIV is not useful in which condition they had asked. Okay. And the option were ILD, cardiogenic pulmonary edema, COPD exacerbation, or post extubation failure. Okay. So, in obviously, NIV is the preferred mode whenever you need positive pressure ventilation in patients who have cardiogenic pulmonary edema or who have, type 2 respiratory failure or hypercapnic respiratory failure. So these two are there, and we also have good evidence for post extubation failure in patients who are high risk for failing the weaning trial or getting reintubated post extubation. In those patients also, we have some data that suggests that NIV helps, but we don't have a lot of data with patients who have, like, ILD, or like ILD exacerbation, or in those patients we don't have a lot of data which suggests that NIV is actually beneficial. So ILD would have been the correct option here. Okay, ILD would have been the correct option here. Question 23. Weaning from ventilators, which parameter to decrease first? PEEP, respiratory rate, tidal volume, or FiO2? So this was the question. Now let me tell you, there is no consensus statement which suggests that you should either reduce PEEP first or FiO2 first. Okay. But in practice, in generally, what we do is we reduce the FiO2 first, and once we, go down to FiO2 less than 50, then we start reducing the PEEP a lot of the time. Okay. So here, probably the correct answer would have been FiO2 based upon best practice statements, but there is no consensus statement which suggests that one should reduce first, like what should be reduced first. Okay. There is no consensus statement there. Okay. FiO2 would have been probably correct answer here. So question 24, patient ventilator dysynchrony despite deep sedation, use of neuromuscular blocking agents, and if then yes, then for what kind of duration? Okay. So we have some trials like Accurasis and Rose trial on it, right? Accurasis trial had shown us that actually, initially it had shown us that 90-day mortality is reduced, but Rose trial did not show any mortality benefit. So whenever you have patients who have severe patient ventilator dysynchrony, and if they are breathing, and trapping air, and which will generate two auto PEEP, which can increase VILI risk. Okay, ventilator induced lung injury risk. So in those patients, it is logical to paralyze them, but the paralysis duration has to be short because it will lead to critical care myoneuropathy or critical care myopathy. Okay. So for to avoid that risk, the duration of neuromuscular blocking agent use should be restricted to less than 48 hours. Okay. So that is what the SEC guidelines or SEC recommendation also tells us. Okay. So this was probably that is what they were testing, and one of the options would have been 48 hours in this question, right? So then somebody had told me that there was a question that which showed ventilator waveform showing decelerating flow with steady pressure. Now I don't know what the options were given, because usually these two, PRVC and pressure control ventilation, both will have similar, constant pressure with decelerating flow patterns. Okay. So if pressure control ventilation was an option, or if PRVC was an option, one of those would have been the correct answer. Okay. Okay. So there was another question somebody had recalled, that in pressure control mode, what variable to change to maintain tidal volume? So obviously pressure, you have to increase the pressure to increase the tidal volume. So if this was the question. So there was another question in ARDS, what not to do during prone ventilation was, like the question was what not to do during prone ventilation. So we usually don't do recruitment maneuvers, and we do not, temper with PEEP a lot whenever a patient is prone. Okay. So we don't. Prosiva trial had shown us that proning for more than 16 hours per day reduced 28-day mortality. One of the best trials done in critical care. You know, uh, they did not do large PEEP adjustment during the turn or during the proning, right? Because it had de-recruitment risk, right? Even if their patient was improving, their oxygenation was improving in the patient, they did not reduce the PEEP. Okay, they did not taper with the PEEP a lot. Okay. And so ART trial showed that recruitment maneuvers also can cause harm in patients who are prone. So basically, you don't do a lot of PEEP titration and recruitment maneuver whenever the patient is prone. Okay. Okay, recruitment maneuver was one of the option as somebody is recalling, and PRVC was one of the option as for those ventilator waveform one. Okay, one somebody is recalling. Okay. Question 28. FiO2 100%, PaO2 60, PCO2 45. What is the cause of hypoxemia? Okay. So probably, so PaO2 60 with FiO2 100%. So this is basically shunt, right? It is not improving with oxygenation. So shunt does not respond to oxygen. Okay. So severe pneumonias, ARDS, atelectasis, usually these cause shunt where your blood just goes to the lung and comes back without getting oxygenated. So this is basically shunting, right? This is basically shunting. You are having right to left shunt, right? So shunt can be intracardiac or intrapulmonary, right? In this scenario, this is probably an intrapulmonary shunt. So this is was an example of shunt. Okay. Anything?
No, let's
Okay.
carry on.
So, question 29 was why was ECMO first derived or developed? So, if you go in the history, ECMO was basically in 1953, given first use it for cardiopulmonary bypass. Okay, so it was basically for cardiopulmonary bypass, and in 60s, membrane oxygenators were developed. In 72, prolonged ECMO was used first by Hill. Okay, in 75, neonatal ECMO, was used, and after 2009, after Caesar trial and 2018 Eolia trial, we have started using more often for ARDS management in critical care as well. So it was basically invented for cardiopulmonary bypass, but it has been like now we use it a lot for ARDS and all of these patients mostly in critical care. Anything to add?
No, no, let's carry
Okay,
on.
okay. VV ECMO, pre-membrane hypoxia, post-membrane good oxygenation interpretation. I did not really understand this question because this is a normal phenomena, right? This is a normal phenomena. So in normally, you will have pre-membranous, you will have low PA2 and high PCO2, PaCO2 values, right? And which basically means that there is a mixed venous blood from the patient. And post-membranous, you will have high PaO2, 300 to 500, right? Which basically tells you oxygenator function, and patient arterial variable targets will be there, right? Yeah, I mean, I did not really understand this question. Why, like, either somebody recalled it incorrectly or what, because pre-membrane hypoxia and post-membrane good oxygenation is actually normal phenomena in ECMO. Okay, it's a normal phenomena in ECMO. Somebody saying cardiopulmonary bypass was not there. If you can recall the options, then maybe we can help you with that. PE was there in option of what? Question 31. ECMO advantage over mechanical ventilation. So whenever you have a patient who has ARDS and you are mechanically ventilating them, even with low tidal volume, like 6 to 8 ml per kg, you are basically, there is a risk of Willy. There is a risk with that repeated, increasing, because the compliance is poor, right? So with that repeated inflating and deflating of the lung, there can be some trauma to the lung. So when we put the patient on ECMO, what we do is we can reduce the tidal volumes to very low, like 4 ml per kg or lower, right? So this basically gives their lung rest. Okay, so you can have lung rest with ECMO. So that is one thing which ECMO has advantage over mechanical ventilators. Okay. Cardiopulmonary bypass was there, then that would have been the correct answer. Okay, so I'm reading the comments. So, question 32, patient on ECMO with heparin, ACT not rising, which drug to start instead? Okay. So, whenever, so heparin basically works by antithrombin 3. Okay. So, it basically, sometimes when there is antithrombin 3 deficiency, either it is congenital or acquired, like in, liver disease or nephrotic syndrome or something like that, your heparin will not work. Okay. So your ACT will not rise. Okay. So if that happens, you have two options basically. Either give antithrombin 3, which can be given, in like in form of FFP also, right? But if you don't have that option right available, then the best option is to change the drug. And usually, what we go for is bivalirudin or ergatobran. Okay, so bivalirudin here was one of the options. So if that would have been the option, then bivalirudin is the correct answer there. Okay. Question 33. So ECMO with adequate flow, but SpO2 not improving. So they had asked the cause. Okay. So ECMO with adequate flow, but SpO2 not improving. So there are multiple causes for failure of oxygenation in ECMO. Okay. So multiple causes are there. But what this describes as is probably recirculation. Okay. It's probably recirculation. It happens whenever the cannulas are very close proximity. So what happens is whatever blood you are putting back in the patient is coming out again to the ECMO circuit, right? So that recirculation is happening. So that is not getting to the patient, and obviously that is why the oxygenation is not improving. What you have to do is, you have to evaluate the drainage and return cannula for color change, right? You have to check pre and post ml blood gas, right? And you have to consider cannula repositioning, or consider reconfiguration to VP ECMO. Okay, so that is what you can do. So probably the scenario was given as recirculation, and recirculation would have been an option. If they it would have been an option, then obviously that would have been the correct. Okay. There was one question of, I can understand somebody's talking about north-south syndrome. So there was one question of that also. I'll come to that also. Okay. Post day 6 ECMO, low fibrinogen, raised D-dimer, patient bleeding. What is the diagnosis? Somebody had recalled the option as DIC or HIT. So, DIC is the answer here, because, everything will be prolonged there. Right. Everything will be prolonged. PT will be prolonged. APTT will be prolonged. Fibrinogen level will be low. D-dimer will be increased. Bleeding time will be prolonged. Right. So platelet count will be reduced. Right. And on peripheral smear, you would see, schistocytes or fragmented RBCs. Okay. So if that was, the DIC was given as an option, then DIC becomes the correct answer there. Okay, and somebody recalled that Eolia trial findings were asked as a question as well. Okay, so Eolia trial, one of the trial, which is landmark trial, which was published in 1918 in NEGM, right, for ECMO. There was a lot of crossover basically, but the primary outcome was that there was a little bit benefit in the ECMO group. Okay, around 35% mortality benefit was there at day 60. Like 35% patients had mortality in the ECMO arm compared to the control arm, 46% mortality, so higher mortality, but it was not statistically significant. Okay. It was not statistically significant, right? So post hoc Bayesian analysis was also done. So it basically shows some benefit. So that is why we use it, right? So even if one of those options were there, then probably they become the correct option. I don't remember, like, some nobody has told me what options were given. So based upon that, I can't comment what was the correct option. So, but yeah, this was the outcome. So outcome was there was no statistically significant mortality benefit, but post-hoc Bayesian, if the collapse is more than 50%, basically, right? Spontaneously breathing patient then. So, shock index definition. So, heart rate by SBP, shock index, right? And if it is normally zero point 0.5 to zero point 0.7. If it is more than 7, it indicates that cryptogenic shock is there. If it is more than 1, it is significant. If it is more than 1.4, then it is, very severe, right? So that is what shock index is, right? And what is a critical value? Probably more than 1 they had given as option or something, more than 1 or something. Hypovolemic shock versus cardiogenic shock, WP, CVP, CI values, right? So the I don't know what options were given, right? In CVP, in hypovolemic shock will be low, in cardiogenic it will be high, right? Pulmonary capillary wedge pressure will be low in hypovolemic, high in cardiogenic, right? Cardiac index will be low in hypovolemic, or can be high also. And cardiogenic will be low, and SVR will be high in hypovolemic, and in cardiogenic it will be high. Okay, so that was that. Cardiac tamponade, also similar kind of a picture they had given, right? So if I don't know what options were given, so basically based upon that only, it will be right. Pulmonary capillary wedge pressure less than LV and diastolic pressure seen in LA myxoma, aortic regurgitation, mitral regurgitation. So these three were the options they had given, that probably like they had asked which was there in it. So normally pulmonary capillary wedge pressure and LV end diastolic pressure are normally equal. Okay, normally they're pretty equal. But whenever you have left ventricle end diastolic pressure more than pulmonary vascular capillary wedge pressure, then it is compensated LV dysfunction or aortic insufficiency, which is aortic regurgitation. If LVEDP, equals to PC, pulmonary capillary wedge pressure, then it's decompensated LV failure. Or if LVEDP less than pulmonary capillary wedge pressure, it is probably MS or MR, okay, with large V waves, okay. They had given V waves in pulmonary capillary wedge pressure indicates, so that was also there, okay. So MR, okay, MR, okay, it indicates MR, yeah, mitral regurgitation, if it was an option, okay, mitral regurgitation. CVP waveform was given: X descent presents, Y descent absent, and they had asked diagnosis. So if that is the like option, then obviously tamponade is the answer there. Tamponade is the answer there. Okay, so it is X descent is present in normally, and Y descent is also present, but in tamponade X descent will disappear. Sorry, exaggerated, and Y descent will be absent, and opposite happens in TR. Opposite happens in severe TR. Your X descent will be absent and Y descent will be present. Okay. In constrictive pericarditis, X descent will be present, but Y descent will be very steep, very prominent. Okay. So that is, if they had given the option as cardiac tamponade, then uh, you know that becomes the correct answer. Okay, that becomes the correct answer. Normal SVO2 and SCVO2 value. So SVO2 value is basically what you get from pulmonary artery catheter. Okay, so 65. Okay, and around 5 to 6% difference is there in whenever you take it from central venous. Okay, so around 70. Okay, so 65 SVO2 value and 70 SCVO2 value. Okay, so 5 to 6% difference is there in SVO2 and SCVO2 values. Okay. So I'm seeing the options, I'm seeing the like stats. So option torsades with defibrillation. Yes, yes, we have that in there. So yes, somebody saying tamponade was given. Yeah, SCVO2 equals to SVO2 plus 5 was an option there for this question. So that is the correct answer. right? SCVO2 equals to SVO2 plus 5. So 5 to 6% difference is normally seen with SVO2 and SCVO2 values. Okay. SVO2 is lower than SCVO2. So SVO2 is around 65. And if that is the criteria, if that is there, then SCVO2 will be around 70. Okay. Will be around 70. So they had given this kind of an ECG, which was resembling. I'm sorry for the low quality. I don't know what happened. Uh, like this ECG of torsade de pointes, right? Torsade de pointes, as we call it. So they had asked the management. So obviously, magnesium is the management. 2 gram magnesium over 10 to 15 minutes. You have to administer, even if the patient has normal magnesium level, according to the protocols. Okay. Anything? It's very cold in Delhi today, and my room has gotten extremely cold. I'm shivering here. It's a cold day in Delhi today. Usually the
Mhm.
case. Yeah, usually the case. So, question 47 was that they had given this ECG and they had asked to identify. Okay, and it is like they had probably given a similar ECG, not this ECG. And this is basically, basically Wenkenbeck phenomena they had shown, and they had asked to identify progressively prolonging PR interval with drop of P waves. They had given probably, and they had asked a management of. Uh, uh, they had asked a management. Somebody's saying Mobitz type 1, somebody's saying Mobitz type 2. See, if it was what I had shown you, if it's Mobitz type 1, okay. If it is no prolongation with sudden drop, then it's Mobitz type 2. I'm not sure what ECG was shown. So it becomes very difficult for me to tell like what is the correct answer because I don't know the correct question. So I'll have to see the ECG to comment on what is correct. So what I'm showing you is Mobitz type 1. Okay. So if that was kind of an ECG, progressively prolonging PR with drop, then it's type 1. Okay. They had shown a ECG of monomorphic VT and they had asked for the treatment option. So I don't know what options were given, but if amiodarone or procainamide would have been in the option, then that if the patient is unstable, then synchronized cardioversion would have become an option. Okay, so I don't know what options were there. Some people are saying prolonged followed by drop. So it was Mobitz type 1 if that was the case. It was a case scenario. Okay. They had shown an ECG with hyperkalemia, potassium 6.5, and they had asked what is the immediate drug. So obviously, membrane stabilization you need first. So calcium gluconate becomes the drug there to give. Okay. So if that is the
Okay, for the previous one, there was no ECG given, only case scenario.
oh okay case scenario only. But that
Probably
is
they have mentioned it as monomorphic VT, I guess.
but then that is the correct answer will be the same, will remain the same with or
Yeah,
without the ECG.
depending on
The
whether the
correct
patient
answer.
is stable or not.
Yeah. Yeah. Okay. So calcium gluconate becomes the correct answer there. And they had asked a scenario with post ACS stenting patient had bradycardia up to 42, which drug to start. And in their noradrenaline, dopamine or dobutamine were the options supposedly. So dopamine becomes the correct option there. So here, this time I've used the correct algorithm of bradycardia, which has both dopamine, epinephrine given. So dopamine becomes the correct answer according to the algorithm. Okay. Heart failure with pulmonary edema, BP 180 by 100 and 100 treatment. Furosemide only, NTG only, or NTG plus furosemide. So, sir, what do you suggest in this? Heart failure with pulmonary edema, BP 180 by 100. furosemide only, NTG only, or NTG plus furosemide?
If it's they are if they are what they are asking is regarding scape, the first thing
Yeah,
should be NTG. Depending on the volume status, we should give furosemide. But I
yeah,
think NTG plus furosemide would be the better option here.
yeah. So I mean, so this is probably a scape kind of a picture because they have given high blood pressure with with failure component, right? With pulmonary edema component. The in scape algorithm, non-invasive ventilation with the NTG is the treatment. But if they're using heart failure also, heart failure with volume overload, then obviously you have to give diuretics as well. So I don't know what exactly they had used in the scenario. So it becomes very difficult to say what would be the correct option. But I think probably NTG plus furosemide would have been the option, as Sir said. But I'm not very sure what would have been the correct option. Depending upon the scenario, it would have been correct because in SCAPE, like diuretics have not a lot of role because scape is a redistribution of fluid, not like fluid overload. So whenever there is fluid overload, you would use diuretics. But if it's just redistribution, then obviously you have to, you know, take care of that with afterload reduction. So I'm not sure what would have been the scenario given. NTG plus Lasix, people are saying was probably the correct answer there. I think the scenario they would have given as NTG plus Lasix. Uh, So BNP is raised in which conditions they had given. I'm not sure what options they were given. They had given, but it is classically used for for ruling out heart failure, not ruling in, right? So heart failure, which is the primary use case scenario, it can be elevated in certain other scenarios, like in the RV failure or RV strain, pulmonary embolism scenario, renal injury, renal failure, reduced clearance leads to increased BNP. In sepsis, because of myocardial depression, it can be elevated in atrial fibrillation or other tachyarrhythmias arrhythmias. In advanced age or, in female sex, sometimes it can be elevated. So I don't know what options were given, but based upon that, would have been the correct answer. Okay. So 50-year-old CAD, right? Stenting, dyspnea, echo shows RV hypokinesia with apical sparing, right? Which was suggestive of McConnell's sign. So, and they had given option as Takotsubo, pulmonary embolism, or myocardial infarction. Whenever you have McConnell's sign, RV hypokinesia with apical sparing, that is McConnell's sign. So, whenever you have McConnell's sign, it is suggestive of pulmonary embolism. Okay, it is suggestive of pulmonary embolism. So, the correct answer here would have been pulmonary embolism. Uh, they had given another question for pulmonary embolism where they had asked what is not seen in pulmonary embolism. RV strain, Westermarck sign, or LA enlarge. So Westermarck sign can be seen in pulmonary embolism. RV strain is seen in pulmonary embolism, but LA enlargement is not seen in pulmonary embolism. LA enlargement is usually associated with atrial fibrillation. Okay, it's usually associated with atrial fibrillation, not pulmonary embolism, and can be associated with atrial fibrillation and stroke, but not pulmonary embolism. Okay, so that's a different kind of embolism. So they had given a scenario of stent thrombosis and asked for management. So the management remains the same, right? You have to give dual antiplatelets and immediate PCI for the patient, right? Immediate PCI would have been one of the option, I believe. Right? Immediate PCI would have been one of the option. So post-ROSC after VF, now with anterior wall MI, does patient need PCI? Okay, post-ROSC after VF, now with anterior wall MI. Okay, so whenever you have post-ROSC in a patient who had, shockable rhythm, the immediate line of management post-ROSC becomes for them to go to cath lab in patients who had shockable rhythm, okay, not for non-shockable rhythm. So this is a scenario with shockable rhythm. So does patient needs PCI? Yes, patient does need PCI. acute MI scenario with nearest PCI center 150 kilometer away. So what to do? So 150 kilometer, whenever it is taking you more than 120 minutes for PCI, then you should thrombolize the patient according to the guidelines. Okay. So thrombolysis is the correct option there. Okay. Thrombolysis is the correct option there. So TB patient on rifampicin, DVT on warfarin died by day 7 with pulmonary embolism. What was the cause? So rifampicin is an enzyme inducer, okay, which induces the CYP enzyme, right, which metabolizes warfarin. So what will happen is the dose will be reduced of warfarin, will not be enough dose of warfarin, right? So the warfarin will not be able to show its action, which is to prevent PE, right? So the patient will ultimately develop PE. So the correct answer would have been rifampicin interaction. Okay. Post-operative DVT, femur fracture with VT, duration of anticoagulation. So this is, whenever you have something which has caused DVT, okay, then the duration is 3 months. Okay. When If this would have been a patient who had, like, a malignancy or something, or some no risk factor would have been found, okay, then it would have been extended duration or lifelong. Okay. But here you have a cause for it, right? So whenever you have a cause, the duration is 3 months. Okay. The duration is 3 months according to the guidelines. Post-surgery CKD 5 patient, earliest anticoagulation to start. So which anticoagulation is preferred in CKD patient? Basically, that was asking. And, unfractionated heparin is the correct option there. Okay. Unfractionated low molecular weight heparin is not preferred because it is renally cleared. So you can expect, you know, uh, weird response. Okay, might increase the risk of bleeding. So unfractionated heparin, because it is, short action of duration, can be reversible completely by protamine, and does not have renal clearance. So that is why it is preferred. Okay. High DVT risk, low bleeding risk, which drug to start? Low molecular weight heparin, always preferred. Okay, low molecular weight heparin. When you don't have contraindications for its use, it is the preferred agent. Okay, for DVT prophylaxis. Preferred agent for DVT prophylaxis, low molecular weight heparin, unless contraindication exists. Okay, unless contraindication exists. Modified Wells criteria is used for, obviously, for PE, right? For pulmonary embolism, right? Or DVT or PE or VT. Correct answer would have been VT, right? Venous thromboembolism risk. Okay. Question 63, CLD on lactulose with recurrent hepatic NCAF, what to add? The answer here would have been rifaximin, okay? Rifaximin, because it is like not systemically absorbed, and it has, according to the ASLD guidelines, it is reduced, it reduces the risk of relapse, okay, in HE patients. So rifaximin becomes the correct answer here. TLD patients, 3% saline for hyponatremia, develops dysarthria, dysphagia, facial palsy, diagnosis, and acute stroke or ODS, osmotic demyelination syndrome, was one of the options. If ODS was the option, then the ODS. It is ODS all the way. Why? Because severe hyponatremia, less than 120, alcoholism, and liver disease, these patients are at very high risk of developing ODS. Okay. These patients are at very high risk of developing ODS. So this would have been, ODS would have been the correct option here. Okay. And there is a waxing and waning kind of a scenario seen. So they get better once you correct their sodium, and then they dip after a few days. Okay. So that kind of a pattern is seen. Okay. So this would have been ODS. Okay, people are saying rifaximin plus lactulose would have been the correct option. Okay. Positive urinary anion gap with severe hypokalemia, type of RTA. Okay. So urine anion gap, sodium minus potassium minus chloride. Okay, sodium plus potassium minus chloride. Okay, so we want fluctuations of electrolytes. Okay, we don't want electrolytes to fluctuate much. CRRT gives you that added benefit because sodium will not fluctuate much, so their ICP will not fluctuate much. So patients who have TBI, who have raised ICP, in those patients we would prefer CRRT over IHD. So answer would have been probably hemodynamic instability would have been in one of the option, and if that would have been the option, then obviously CRRT like hemodynamic instability becomes the correct answer there. Okay. Hypokalemia with metabolic acidosis, fluid of choice, sir, option like RL, NS with KCl, D5 with KCl are the option there. Hypokalemia with metabolic acidosis. Do you want to weigh in? Because like I'm very hypokalemia with metabolic acidosis, fluid of choice they had asked. RL, NS with KCl, and D5 with KCl are one of three of the options which were recalled. I would rather go with RL because NS causes nagma. And if metabolic acidosis they are giving, then they probably don't want you to exaggerate that metabolic acidosis. And that is what they were probably trying to figure out. But the problem with RL is it has lectate. So whenever you have like, liver problems and all that, then it is usually not preferred. But in this scenario, I think RL would have been the correct option because RL, NS causes, nagma. Okay. ABG finding in ACOPD. Somebody is writing, wait, let me see. Video is stuck. We have asked the team to check it once if there is some problem. Uh, Apixaban is, if they're live, then I'll wait. Are we live?
Not yet. There is some technical problem. Yeah, I think now
So
we are
then
back.
I'll take,
And now we are back. Yeah.
not yet showing.
Screen.
Okay, yeah, okay, we are live. Okay, so there was some technical difficulty. So I was talking about calcium phosphate product. If it's more than 55, then you avoid. If it's more than 70, then it's an indication for dialysis. But nowhere it says that calcium should not be given in tumor lysis syndrome. Okay. Anyways, and we have discussed all the questions 65, 67, 68. If it probably the YouTube jumped because you were watching live, so you can go back and check later. Okay. So ABG finding in acute exacerbation of COPD was one of the questions. I'm not sure what was given. So, but you will see pH will be low, or low normal if compensated, then PCO2 will be high and bicarb will be high based upon compensation. And compensation is usually you can remember it easily by 1, 2, 3, 4, 5 rule, right? For every for acute acidosis, for every 10 millimeter increase in PCO2, your bicarb increases by 1, and for like chronic, it increases by 4. Okay, for like alkalosis, 2 and 5. Okay, acute and chronic. Okay, so ABG of a vomiting patient. So vomiting, what happens is you basically vomit out all the HCl, right? And because of that, there will be volume depletion. So you are vomiting out HCl, so there will be metabolic alkalosis, right? And because of the hypovolemia, there will be RAS activation, which will lead to you know wa- like wasting of potassium, right? So you will see metabolic alkalosis with hypokalemia, okay, classically. So your pH will be high, your pH will be high, your PCO2 will be compensated accordingly, right? Your PCO2 will be compensated accordingly, will be increased, right? And your potassium will be low, right? And you will usually have urine chloride low, like right, less than 20, right? So that will be there. So I don't know what was the ABG which was given. So the vomiting patient, that will be the ABG. Okay. Okay. So pH 7.5, PCO2 28, chronic respiratory alkalosis, expected bicarbonate. Okay. So again, you can easily calculate it with 1, 2, 3, 4, 5 rule, right? So it is chronic respiratory alkalosis. So for every 10 change in PCO2, the bicarb will change by 5. Okay. So it is chronic respiratory alkalosis, right? So the change in PCO2 is, 12. Okay. So the bicarb will 1.2 into 5 will be around 6. Okay. So bicarb will change by 6. Okay. So reduce by 6. So 24 minus 6 is 18. So the correct answer will be 16 to 18. Okay. So that is how you calculate uh, PCO2, like bicarb for respiratory compensation. 1, 2, 3, 4, 5 rule is best. Okay. It's easy and it's best. Clostridium difficile, drug of choice. Now, this is a tricky one. Okay. Uh, Oral vancomycin, somebody recalled IV fidexomycin and metronidazole. So the correct answer would have been fidexomycin. But if it is IV, then it is not correct because IV fidexomycin doesn't exist. Okay. So IV fidexomycin doesn't exist. If oral fidexomycin would have been given or just fidexomycin would have been given, then answer would have been fidexomycin. But since IV fidexomycin does not exist, oral vancomycin becomes the drug of choice there. Okay. 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 MRSA, drug of choice. So vancomycin is the drug of choice for MRSA. Okay. Vancomycin is the drug of choice for MRSA. Most common organism for clepsy. So Clepsy, the most common organism, is what stays on the skin. Your cons, right? Coagulase negative staph aureus, right? Right. So that is your most common organism for Clepsy. Okay. I don't know what were the options, but cons would have been one of the option. Okay. So least infection rate CVC site. Usually, subclavian is considered the least infection, followed by jugular, internal jugular, followed by femoral. But the latest data, current recent data, is suggesting that femoral and jugular are almost the same. But yeah, if you are using for exam, then traditionally subclavian, internal jugular, and femoral. Okay, subclavian, internal jugular, and femoral. VAP prevention bundle component. So there was a 2022 update for VAP prevention bundle. I don't know what was given as the option. So, you have to avoid intubation and prevent re-intubation is the first one. Minimize sedation, maintain improved physical conditioning, head of bed elevation, oral care, right? Daily toothbrushing. Chlorhexidine is not routinely recommended anymore. Provide enteral nutrition, early enteral nutrition, manage ventilator circuits appropriately, utilize endotracheal tube with subglottic secretion drainage, right? Implement ventilator liberation protocol. So I don't know what was the option there, but you have to, head of bed, oral care, early enteral nutrition, mobilization, right? One of those would have been uh, all the options. So head of bed elevation, somebody is saying, so that would have been your correct answer. Okay. So febrile neutropenia, first sign of infection. There would have been more option, but somebody had recalled GI symptom before fever and only fever. So what happens is whenever you're neutropenic, you're immunocompromised, you might not be able to mount the inflammatory response. You might not have pus development. You might not have, your inflammation signs. You only sometimes just get fever. So that is why fever at any rate is treated very seriously in patients who are immunocompromised or who are neutropenic. Okay, so only fever was probably the correct answer there. Okay. Question 80, febrile neutropenia, day 4, not resolving on antibiotic. What is the next step? Okay. What is the next step? So, next step, whenever you have febrile neutropenia and the patient is unresponsive to your IV antibiotics, think of fungal. Think of candida. Okay. Think of fungus as culprit and add antifungals, usually echinocandins are the preferred ones. Okay, usually we add echinocandins, so that would have been the correct answer there. Okay, what is happening? Severe cap, gram-positive diplococci, drug of choice. So severe cap, gram-positive diplococci. Gram-positive diplococci is probably strep pneumonia. Okay, probably strep pneumonia. Strep pneumonia with severe cap. So according to the IDSA guidelines, okay, according to the IDSA guidelines, patient with in-hospital treatment, severe cap, no risk of Pseudomonas or MRSA. So they're here. Those two have been ruled out, right? The drug of choice are usually beta lactams with a macrolide or respiratory fluoroquinolones. Okay, beta lactam with macrolide would have been one of the option, either ceftriaxone with azithromycin. That is the usual drug which we all use in our practice as well, right? So that would have been the option. Okay, why is my computer not working properly? Cap ICU antibiotic with MRSA Pseudomonas risk. So, so this is what I had already told. So this is from the IDSA guidelines, right? So, you have whatever no MRSA and Pseudomonas risk. You have beta lactam and macrolide if the patient has severe infection. If the patient has non-severe infection, you can choose between respiratory fluoroquinolone and beta lactams, right? Uh, if Trixone and Azithro was there, somebody saying, so that would have been the correct answer, right? And if MRSA risk factors are present, then based upon that, and Pseudomonas risk factor are present, then based upon that, right, you can decide to choose empirical treatment, okay, after obtaining cultures. Okay, so beta lactam options are ampicillin sulbactam, cefotaxime, ceftriaxone, and ceftraroline. Okay. So VAP day 9, Pseudomonas sensitive to meropenem, amikacin, colistin, which to start. So Pseudomonas with VAP, right? Meropenem would have been the correct answer there, right? Meropenem would have been the correct answer there. Uh, so colistin is usually reserved; it's not usually given, right? And unless we have tried other options, right? It's usually reserved, and it is not very preferred drug. Okay, and amikacin is not usually preferred for severe infections, especially patients who have hospital-acquired infections. Okay, sometimes their resistance might be there. So meropenem would have been the correct answer there. Okay, pneumonia on meropenem plus vancomycin, day 3, culture negative, PCT negative. Uh, like what is to do next? Okay, so this is probably a picture of, like, you don't have a bacterial infection because your cultures are negative and your procal is also negative. Okay, your procal is also negative, your culture are also negative, and you had started patient on a broad spectrum antibiotic, mero plus vanco. So this is time to rethink and de-escalate. So according to antibiotic stewardship, like after 42 to 72 hours, whenever you have culture reports with you, this is the time to take a pause and rethink your strategy of, like you have to de-escalate your antibiotics. Okay, so if de-escalation was the option, then that would have been correct option. Here somebody recalled continue for 7 days, add antifungal and stop antibiotics. So in that, the most correct answer would have been to stop antibiotics. Okay. Depending upon patient responsive or not, also that is also you have to keep in mind. Okay, urosepsis with shock management. So according to the 2025 guidelines, so sepsis with or without shock preferred are third and fourth generation cephalosporin, right? Carbapenems, piperacillin, tazobactams, and fluoroquinolones, if that was the option. Obviously you have, it's a septic shock, so you have to do all the bundle of sepsis also with it. You have to fluid resuscitate the patient, you have to take, like cultures before giving antibiotics, you have to measure lactate, remeasure if elevated, all of those things you have to do in septic shock. Okay, but if it's about antibiotic, then these are the options which you can have for antibiotic. So one more option was to continue for 5 days and observe, change to so see, with CAP, the guidelines say that uh, shorter course of therapy, okay, 5 days, okay, is the shortest course for CAP, which has found to be as effective as 10 days, okay. So you can give the patient antibiotics for CAP for 5 days. But if the CAP is bacterial, but here the picture is like that this is probably not a bacterial CAP, this is probably a viral CAP, so antibiotic won't be a lot of benefit here. So in that scenario, the correct option would have been to stop the antibiotics, if not de-escalate, okay? And they had shown a CT or they had asked PCP pneumonia, what are the radiological findings? So this is a CT of PCP pneumonia, pneumocystis jirovecii pneumonia. You can see bilateral, widespread ground glassing on the CT. Okay. So ground glassing, widespread ground glassing is actually one of the uh, key defining feature in radiological feature in PCP pneumonias. Okay. So ground glassing GGOs were the correct option there. Okay. Halo sign on CT is seen in. So halo sign is that there is a dense consolidation or a nodule surrounded by a ground glassing. Okay. And reverse halo sign is opposite. Ground glassing surrounded by a consolidation. Okay. So halo sign is classical of invasive aspergillosis, pulmonary invasive aspergillosis. Okay. So that is aspergillosis was probably in the option, which would have been the correct answer. Right. So that reverse halo sign can be seen in TB, can be seen in aspergillosis, right? Cryptogenic organizing pneumonia can also be seen in that. Okay. Yeah, silofiller, I'm coming. Okay. Serial lactate measurement in septic shock significance. Okay. Serial lactate measurement in septic shock significance. So there are two significance. First, you have to monitor. It helps you in knowing whether your therapy is working or not. Okay. If your lactate are reducing every 2 to 4 hours, at least 10 to 20%, then you know that your therapy is working. Also, it helps you prognosticate. So it helps you prognosticate in the sense that people who do not have lactate improvement with the adequate therapy, they usually end up doing worse. Okay. They usually end up doing worse. So it does two things. Okay. It helps you in your treatment monitoring and also in prognostication. Okay. So both of the things it does. Okay. I don't know what were the options. So I don't know. Like one of those two options would have been there, and that would have been the correct answer. So antibiotic timing in sepsis and septic shock, we all know 1 hour. Uh, you should take culture before antibiotics, but should not be delaying antibiotics unnecessarily for culture if you cannot take culture, right? And also, with each hour delay post 1 hour, with each hour delay in antibiotic giving increases the mortality by 7 to 10%. Okay, some places have even written 13%. Okay, so it's a significant mortality rise. So you should be giving antibiotics within the first hour of diagnosis. Okay, I always keep fighting with my nurses. So, neutropenic fever, reason for routine cultures before antibiotics. Okay. Reason for routine cultures before antibiotics, it can help you narrow your spectrum. Okay. It can help you. So, the whole sole point of culture is it helps you identify the pathogen. Once you identify the pathogen from broad spectrum, you can go to narrow spectrum. Broad spectrum has problems because it will give rise to resistance. So if you are giving meropenem for somebody for a very long period of time, what it will do is it will, select the CRE bugs because other bugs will die. The CRE bugs will stay alive. Those CRE bugs will start proliferating now and they will become the normal flora. Right. So the next time person gets infection, it will be CRE infection. Okay. So that is why narrowing of therapy is very important. Okay. Narrowing therapy is very important. And that is the main sole point of culture. Okay. That is the sole point of culture. Nanotechnology, digital PCR in sepsis use. I don't know what the question was, but it was related to that. So we use digital technology, PCR technology in sepsis to quickly identify. So cultures usually take 48 to 72 hours to show you a yield. Although most cultures will become positive within the first 24 hours, but to get the final report, you need to wait for 48 to 72 hours. However, if you are doing biofire or something, some PCR like that, right? Or Malditov or something, you will get the results within a few hours. Okay, within a few hours. So that you can narrow your therapy early. You can think about narrowing your therapy, think about, targeting the correct pathogen early. Okay, so that is the sole purpose of it. Okay. Principle of precision medicine in critical care. So precision medicine is basically, it allows you to, you know, treat based upon, like, personalized approach. Okay, so personalized approach, your genomic approach. You have ARDS, whether it is hypoinflammatory, hyperinflammatory. So that personalized approach you can use with use of precision medicine. Okay, so that is the use. I don't know exactly what the question was, but it was something related to principle of precision medicine in critical care. Okay. So that is the correct use of precision medicine. Okay. So health versus preeclampsia difference was asked. So right hypochondriac pain with normal LFT or transaminitis. Transaminitis would have been the correct answer there, because HELP syndrome, you will see low platelet and transaminitis. Okay, that is a defining feature, and you will see some, pain also might be present. But transaminitis with low platelet, elevated liver enzymes, which is transaminitis, basically that is what HELP syndrome is about. That is in the name only. That is in the name only, right? Question 94, 34-week pregnancy, seizures, eclampsia, managed with magnesium sulfate. What is next? 34, deliver. Okay. Delivery would have been one of the options, I'm pretty sure. And that would have been the correct answer. Okay. That would have been the correct answer. Let me know if that was not the case. Okay. Delivery would have been one of the options. 34-week pregnancy, pink frothy sputum, hypertension, diagnosis. So postpartum cardiomyopathy, right? And your embolism, right? Amniotic fluid embolism, ARDS, preeclampsia with pulmonary edema. So obviously hypertension with features of pulmonary edema. So that is preeclampsia with pulmonary edema, right? That is preeclampsia with pulmonary edema, right? And this is not postpartum cardiomyopathy, because there is not postpartum, right? Personalized approach was the option, then personalized approach is the correct answer. Okay, personalized approach is the correct answer. And yes, delivery was there, as people are saying. Okay. So preeclampsia mechanism. So obviously, we have all read about the preeclampsia mechanism. So it's a two-step process. First, your spiral arteries, the trophoblast is not basically does not proliferate till spiral arteries, right? Does not reach till there. So it causes resistance, and over period it causes, hypoxia, which leads to vasoconstriction and all the problem. Okay, so preeclampsia mechanism, we all know. Okay. Highest risk for preeclampsia. So 22-year with previous stillborn, and probably this was preeclampsia. 22 years with juvenile diabetes mellitus or obesity, BMI more than 35. So there are multiple risk factors for preeclampsia. Okay, multiple risk factors for preeclampsia, but the highest weightage is of preeclampsia in a past pregnancy. If that was the option, right, it has 8 times more risk. Okay, if that was the option, then that would have been the correct option. Okay, that would have been the correct option. I think the 22-year-old previous stillbirth preeclampsia or something would have been the correct option there. So preeclampsia, aspirin prophylaxis dose, and when to start. So according to ACOG guidelines, okay, according to ACOG guidelines, you have to start 75 milligram of aspirin in patients who are at risk of developing preeclampsia, higher risk of developing preeclampsia, between 12 to 16 weeks. Okay, not after 16 weeks. So you should be starting it before 16 weeks, not after. That is not the correct term to use, but before 16 weeks, between 12 to 16 weeks, and should continue till delivery. Okay, 75 milligram aspirin to prevent it has shown to reduce the risk of developing preeclampsia by approximately 17 to 20%. Okay, the ACOG guidelines suggest that you should start it between 12 to 16 weeks. Okay, to prevent preeclampsia. Okay, okay. Vasopressor of choice in pregnancy, norepinephrine is usually the first line pressor in sepsis in pregnancy or any other scenarios. Okay, so norepinephrine would have been one of the options, which becomes the correct option. Okay. I'm not sure what the options were. Somebody is asking previous stillborn could be due to reasons. I'm not sure what was the correct option there. Uh, but if they had preeclampsia in the previous pregnancy, that is one of the highest risk. Okay, that is one of the highest risk. So if that was there, preeclampsia in a past pregnancy, which could have led to, stillborn or stillbirth or something like that, that would have been your correct answer. Okay, that would have been your correct answer. Okay. And there are multiple other risk factors for preeclampsia. So I think then previous stillbirth, 22-year with previous stillborn would become the correct answer there, because that stillbirth could have been due to preeclampsia. Okay. That considering you are thinking that it is probably preeclampsia, right, in the previous pregnancy. So, methicillin susceptible staph aureus bacteremia in an immunocompromised patient, what is the duration of antibiotics? So you should minimum give for 14 days. Okay. Minimum give for 14 days. If there are no deep-seated infections. Okay. If there are no deep-seated infections like endocarditis, then you give it for 14 days. And if the culture has become negative after 40 to 72 hours, and the patient is showing improvement, you can stop after 14 days. If not, then you need to continue the therapy. And if it is endocarditis or some deep-seated infection, then you have to give it for longer period than up to 6 weeks or something. Okay. So, severe traumatic brain injury, ICP is 25 millimeter, MAP is 80. Next step to reduced ICP. So there is a tiered approach to ICP. Okay, if you read the guidelines, BTF, Brain Trauma Foundation, fourth edition guideline or something, you will see, or even if you read, Seattle guidelines or something, 2019, which came out. So whenever you read these guidelines, there's a tiered approach to management of raised ICP. Tier zero is whoever is suspected to have brain injury, all should receive it. Okay. So airway, breathing, circulation, head of bed to more than 30-degree elevation, right? Midline head position, cervical collar fit to, so that it is not compressing on your jugulars and impeding the flow, right? And normothermia, steroid for tumor-induced vasogenic edema, analgesia for pain, sedation, right? Anti-seizure medication if warranted, and avoid hyponatremia. So these everybody should receive. But if somebody has raised ICP, like this patient who has 25 millimeter of ICP, and when your ICP should not be this high, right? So when somebody has raised ICP, then you go to tier one. If that is not maintaining, then you go to tier two. If that is not maintaining, then you go to tier three. So the next step is to go to tier one. In tier one, you have, so one of the options was mild hyperventilation, increased sedation, add paralysis. So these are next tier. The in first year, only mild hyperventilation, PaCO2 goal of 35 to 38 is there. Okay. So the first year approach, you should go first, then to next year, then to next year. Okay. So mild hyperventilation is the first year approach. So that is what you should do. Here's mild hyperventilation. Okay. Hypothermia in TBI, what is the correct evidence? So, there were two trials published recently in 2015. There was this trial called Endotherm 3578 or something. And then there was another trial in 2018 called Polar trial. Okay. Both have shown that hypothermia does not improve outcomes. Hypothermia does not improve your neurological outcomes. What is the correct evidence? The correct evidence is that it does not work. Okay. So the best approach is to not let them have fevers. Maintain normothermia, avoid fevers. Okay. So that is the approach. Hypothermia does not work. Okay. So avoid it. Should be avoided. Hypothermia should be avoided. The correct answer is that. Okay. Treatment refractory epilepsy, which brain location? So whenever you have treatment refractory epilepsy, most of the time it is associated with mesial temporal lobe sclerosis. Okay. Mesial temporal lobe sclerosis. So temporal lobe, if that was there in the option, then that would have been your correct answer. Okay. Mesial temporal lobe sclerosis causes refractory epilepsy to drugs, multiple drugs, and that is what would have, I think this is what they were asking, and that would have been the correct answer if temporal lobe was there in the options. Okay. Why levetiracetam is preferred over, okay, my computer is about to get shut down. One second. Why levetiracetam is preferred over phenytoin in TBI or SOL, okay, space occupying lesion or TBI. I'm not sure what they had given in the question, but this is somebody had recalled. So the phenytoin is an, it interacts with the enzymes, okay. So it has multiple drug-drug interaction. Levetiracetam is not an enzyme inducer, so it does not have the drug-drug interaction. And when you have a patient who have space-occupying lesions, you end up giving them steroids, you end up giving them chemotherapy. So that drug-drug interaction becomes problematic. So that is why you want to give a drug which does not have a lot of drug-drug interaction. Okay. Uh, so that is probably the correct answer there. Okay. Drug-drug interaction. CPP ICP map relationship. So CPP equals to map minus ICP. So that is the relationship. Okay. Cerebral perfusion pressure equals to map minus ICP. So your flow minus resistance, right? That is basic physics, right? Your flow minus resistance. So that is what CPP is about, cerebral perfusion pressure, and that is the relationship. Okay. I don't know what were the options, but that is the relationship. So you increase your map, your CPP will increase. You increase your ICP, your CPP will reduce, right? So that is the relationship. Prolonged paralytic use, sensory is intact, but patient has motor weakness and they probably are having weaning difficulties. What is the diagnosis? And distal neuropathy or critical critical illness myopathy or something, or polyneuropathy or myopathy was given in the option. So critical illness myopathy or polyneuropathy is the correct option there. It will have sensory sparing. Okay. It will mostly be motor. It will have sensory impairing. The risk factors are septic shock, prolonged illness, use of steroids, polymyxins, right? And neuromuscular blocking agents, some certain antibiotics like polymyxin. So all of these are risk factors. So when somebody nutrition deficiencies, all of those things, so these becomes your risk factors. So this is classical sensory sparing, motor weakness. So this is critical illness, polyneuropathy or myopathy. Okay. Calcium channel blockers or beta blockers poisoning, refractory to glucagon and calcium. What is the next step? So ABP, dialysis, high dose insulin, ECMO. So the next step is always high dose insulin. You give 1 unit per kg bolus followed by zero point 0.5 to 1 unit insulin per kg infusion and dextrose infusion to maintain the sugar level between around 200, 200 to 300. And you after that also patient is not, so what it does is basically your heart is becomes because of all these calcium channel blockers and beta blockers, your heart is having issues, right? It is not contracting well. So these high dose insulin actually sensitizes the myocardium. Okay, it improves the contractility. Okay, so that is what it does. If that also doesn't work, then you go for lipid emulsion or ECMO. Okay, so first step is to give high dose insulin therapy. Okay, first approach is to give high dose insulin therapy. If the patient had severe hemodynamic compromise, then ECMO would have become an option if the patient was not getting maintained. But usually these patients will have hemodynamic compromise. So, anyways, the first step is to give insulin therapy. If the patient's still not improving, if the patient has refractory shock or something like that, then go for ECMO. Okay, then go for ECMO. And obviously, you'll have to go for VA ECMO. Okay. Yeah. What is the mechanism of propofol infusion syndrome? So, propofol infusion syndrome is seen whenever you use propofol infusion for a prolonged period of time, right? More than 5 days, high dose propofol doses you're using. Okay. What it does is basically you will see metabolic acidosis, rhabdomyolysis, hyperlipidemia, bradycardia, cardiac failure, and hepatomegaly. And it happens because propofol inhibits mitochondrial respiratory chain, complex 2 and 4, and fatty acid transport to mitochondria. Okay. And that is why it has happened. And risk factors are prolonged infusion, more than 48 hours, high dose, right? 4 to 5 milligram per kg per hour, young age, and critical illness. Okay. Yeah, medium chain fatty acid oxidation would have been the correct answer. Okay. So, citrate toxicity in massive transfusion with hypocalcemia treatment. So you are giving massive transfusion, you have, citrate toxicity. Obviously, the treatment citrate chelates calcium, so the treatment is calcium gluconate. Okay, the treatment is calcium gluconate. To prevent it, that is why you give after every 4 units of blood, you give calcium, right? To prevent it, right? Your ionized calcium goes less than 1, it becomes problematic, right? To prevent that, you give calcium with every 4 to 5 units of transfusion. Okay, that is the mechanism because citrate chelates calcium. Okay. Patient on inhaled nitric oxide develops cyanosis. What is the treatment? So nitric oxide can, cause the treatment is methylene blue because it can cause. Uh, Wait, what happened? I think I'm sleepy now. Can you come in, please? I need some water. I think 1 second. Just give me a minute. I'll only take over. Just give me a minute. Okay, sorry. My brain had stopped working for a minute. Uh, nitric oxide can cause methemoglobinemia, right? To treat it, you give methylene blue, right? And the correct option would have been methylene blue, right? And that is the correct option. And yeah, so somebody had given is like the question that this there was a Silofar disease or something. I wasn't very sure. I think it was Silofiller's disease. Okay, Silofiller's disease. So what happens is, so there are these big silos, right, where they store grains and all the produce which have come from farming. Okay, so they put it there, they close it, and if somebody goes in for initial 2 days, okay, within initial first 2 3 days, what happens is there is production because of the bacteria. There is production of gases like nitrogen dioxide and NO2. Okay, nitrogen dioxide. If somebody inhales that gas, nitrogen dioxide, that nitrogen dioxide with the moisture in the lungs gets converted to nitric acid. Okay, and that acid can cause, severe injury to your lungs and bronchioles and alveoli and all of that. Okay, it can cause inflammation and ARDS and organizing pneumonia as well later on. Okay, so that becomes the problem. So I think in one of the option you would have seen nitrogen dioxide or nitric acid as one of the option. If somebody can please let me know if nitrogen oxide or nitric dioxide or nitric acid was one of the options or not. Yeah, N2. Somebody has written NO2. Yeah. Yeah, cellular disease. Okay, thank you. Most common cause of acute respiratory failure in oncological ICU, I've already told previously. So, one of the most commonly people who have respiratory failure, they are usually because of some sort of pneumonia or some sort of respiratory infection or pulmonary infiltrates. Okay. So the correct answer here would have been pneumonia or pulmonary infiltrates. Okay. So one of the question was type 1 chemotherapy induced cardiac dysfunction. What is the mechanism? Okay. What is the mechanism? So there are two types of chemotherapy-induced cardiac dysfunction. Type 1 is basically which is, irreversible. Okay. Basically, your myocardial injury happens. Okay. Your structural damage happens. And that is why it is irreversible, and it is usually dose related, and it is seen with drugs like, anthracycline group like doxorubicin. Okay. And there is type 2, which is reversible and which is not dose related. It is basically functional problem. That is trastuzumab and bevacizumab. Okay, so these cause it. Okay, so the correct option, I think they would have given structural disease or something like that. They would have given, uh, in the options. Okay, yeah. Okay. Uh, so tumor lysis syndrome with potassium 6.8. Perioral tingling. So there is hypocalcemia. Okay. Immediate first action. Okay. So what tumor lysis syndrome does is basically increases your potassium. Whatever is inside the cell will come out. Okay. So potassium will come out. Phosphate will come out. So potassium will increase. Phosphorus will increase. And that phosphorus will bind to calcium, which will cause hypocalcemia. Okay. That hypocalcemia is causing the perioral tingling, right? So what is the first action? So what will you do? Can you do dialysis here? It will take you a long time to do dialysis, but the patient might develop seizure because of hypocalcemia. Patient might go into cardiac arrest because of hypocalcemia or hyperkalemia. So the best step, the immediate first action is to actually give calcium gluconate to correct that hypocalcemia and to membrane stabilize that hyperkalemia thing, right? So that is the best step which you have to give. Obviously you are giving other things, you have to take care of it. You have to take care of your phosphate, you have to think about calcium phosphate product and all of those things. Give dialysis, do dialysis, give rasburic for your uric acid and all of those things later on. But first thing you have to do is you have to correct the hypocalcemia and you have to correct the hyperkalemia. Okay. I'm not sure if there were two questions because people have actually given me as two questions. So I am not sure if it was one question only with ECG findings or if there were two questions. Somebody has said one was with ECG. Somebody had sent only this case scenario without ECG. So I'm not sure. I am only making recall based upon what was recalled to me. Okay, only one question was there. But yeah, calcium gluconate is the now again one, but somebody is saying TLS. One more question is there. So cause of seizure is hypocalcemia and TLS. Okay. So cause of seizure is hypocalcemia. So two question of TLS was there. Okay. I don't know if the another question of hypercalcemia was there or not, or only that question is there for TLS. So, anyways, you are giving calcium gluconate for hypocalcemia and uh, your hyperkalemia, and for management of seizure also. Most common cause is hypocalcemia, so you will have to give calcium. Excuse me. So, morphine versus tramadol in immunocompromised patient. So, opioids, some opioids like morphine have some immunomodulatory property. Some antibiotics and some other drugs also have some immunomodulatory property. Okay, morphine basically it causes it reduces the function of natural killer cell. Okay, it modulates the function of natural killer cell. Okay, so if you have a patient who's oncological patient where you have to monitor their you know uh, immunomodulation and all of that, in those scenarios you would prefer tramadol over morphine. Okay. Okay. You would have to prefer tramadol. Okay. In those scenarios. So that is one question which was told, that some question was there between morphine and tramadol in immunocompromised patient. I think that would have been the option, that immunomodulation or natural killer cell function or something. Morphine has that property which tramadol does not. Okay. Issue sedation the agent of choice. According to the PADIS guidelines, the recent PADIS guidelines, dexmedetomidine is preferred ICU sedation of choice because it causes first, uh, it has it causes less delirium. Okay. It causes less delirium. And because of that less delirium, your patients will have less post-intensive care syndrome. Okay. So you need to have less delirium in your patient, because delirium increases, your ICU length of stay, your morbidity, and even in some scenarios, mortality. Okay. So it is very important to reduce delirium in patients whenever you are choosing sedation. Okay. Dexmedetomidine has also one more function, that it suppresses respiratory, there is less chances of respiratory depression. So that is also there with dexmedetomidine. So it currently in after Mind USA trial and all of those trial, it is becoming preferred agent in PADIS guidelines. Also, recent PADIS guidelines also, it is becoming as preferred choice. Okay, 30 minutes post transfusion, fever and pulmonary edema. Uh, Diagnosis. So Trali is the diagnosis. Okay, transfusion associated lung injury. Okay. So it is usually the 6 hours is the criteria. Okay. So if it is happening too late, it is not Trali, right? It can be, but usually not Trali, right? So Trali would have been one of the options there, right? So Trali was the correct answer. So cryoprecipitate, does it need cross-match? So cryoprecipitates are formed, by thawing the blood, right? And contains almost all the factors which FFP does, right? But it is majorly given for use for fibrinogen. Okay, fibrinogen factor 8, von Willebrand factor 13, fibronectin, all of that is contained. And then after thawing, it is mixed with, it is centrifuged and mixed with 10 to 15 ml of some plasma. Okay. So that is how it is used. So since it contains very little plasma and no cells, so the cross match criteria is not hard and fast. It is preferred that ABO compatibility is should be there, but it is not hard and fast. Okay, it is not a cross match criteria is not there. So it does not actually require cross matching. Okay. Taco will not be there. Fluid overload is not be there. It is fever is also there. No, only pulmonary edema may be taco, but fever is also there. So there is some inflammation going on. So once inflammation is going on, taco will be ruled out. Okay, taco will not have inflammation. Taco will only have pulmonary edema. No, no fever. Okay, if you are having fever, you have to think of some inflammation. So inflammation is seen whenever there is injury. Okay, so injury is because of Trali. I don't know. There are two questions. Somebody said they had asked 1 unit of RDP increase platelet by it does by around 10,000. And somebody had said 1 unit of SDP, so it increases by 30 to 60,000. Okay, between 30 to 60,000. I'm not sure which was there, so I've included both. Okay. Lethal triad of trauma. I think very little questions came from trauma, sir, this year. Only like one or two questions are there. My massive transfusion protocol, that one, and this lethal triad of trauma. Coagulopathy, hypothermia, and metabolic acidosis is the lethal triad of trauma. If you say, tetrad, then you add hypocalcemia also, right? But lethal triad is the classical, and coagulopathy, hypothermia, and metabolic acidosis. Okay. RDP is 10,000. Okay, RDP, people are saying RDP was there. So 10,000 is the correct answer. Okay, 10 into 10 to the power 3 is what has been given everywhere. Okay, 10 to the power 3. So this is around 10,000. Okay. AAP measurement, which statement is false at end expiration, supine position at end inspiration. I've taught in the class also. So WSACS guidelines suggest to measure AAP in supine position at end expiration, and where you zero at the mid axilla. Okay, you zero at the mid axilla. Okay, so these three criteria should be fulfilled for you to measure IAP or intra-abdominal pressure. Okay, so for abdominal compartment syndrome. Okay, for raised IAP. So I think end expiration would have been the correct option there. Okay, end expiration would have been the correct option there. Uh, IBP or invasive blood pressure at dorsalis PD, how will map compare to central? So what peripheral like uh, uh, peripheral blood pressure reading, what it does is basically it increases your systolic and decreases your diastolic compared to central. Right. Compared to central, your systolic will be higher as peripheral you go, and diastolic will be lower. But map will stay the same. Map will stay the same. Okay. More or less same. Okay. Unless it is severe shock or something, then in those scenarios, map might change. But in normal scenarios, your map will be the same. Increase systolic, reduce diastolic. Okay. Increase systolic, reduce diastolic. Yeah, false is end inspiration. I don't know if it was true or false. Then true is end expiration, false is end inspiration. So end expiration is the criteria, not end inspiration. End inspiration is not the criteria. So true is end inspiration, false end expiration, and false is end inspiration. End expiration is the criteria, not end inspiration. Okay. Overestimate systolic and underestimate diastolic. Okay. So auscultation below scapula near vertebral column, which lobe? Okay. So whenever you're below scapula, you are auscultating the lower lobes. Okay. You're auscultating the lower lobes. Posterior side, lower lobes. Okay. Okay. Patient on NIV, how to give nebulization, remove NIV and nebulize, or inline nebulization. So patients who are on severely dependent on NIV, who are on severe respiratory failure or something. Okay. Uh, so in those scenarios, it's always better to give inline nebulization. Okay. Connect the nebulizer in line. Okay. So that is always preferred. Inline nebulization is the preferred choice. Okay. 5 year old, I didn't understand this question. I'll be very frank with you. Okay. 5 year old with raised ICP, permissive hypercapnia is contraindicated if. So anyways, in with raised ICP, permissive hypercapnia is contraindicated. I didn't understand this question at all, but I think the correct answer here would have been pulmonary artery hypertension, because pulmonary artery hypertension will worsen. Your right heart pressures will worsen if you have more hypercapnia in this scenario. Okay.
The previous question, I think it was in nebulization on how to give MDI.
Then you'll have to remove the mask. MDI you can't give inline. Meter dose inhaler, how will you give inline? You can't give inline.
I
You
think that
can't
will
give
be
him.
that.
Yeah, that you can't give like inline. MDI can't be given inline.
Mhm. Okay. There is a confusion whether there are two questions regarding that. Let's move on.
Okay. Yeah, okay. Curve 65, which is not a component. A is urea, heart rate, temperature. So it is an easy question. C for confusion, U for urea, R for respiratory rate, B for blood pressure, A for age. Heart rate is not there. Okay. Heart rate is not there. The correct answer was heart rate. Okay. So risk reduction 40 to 35, calculate number needed to treat. So number needed to treat is 1 by ARR. Okay, risk reduction. So in this scenario, the absolute risk reduction is 40 minus 35, that is 5%, which comes to 0.05. Okay, 0.05. So 1 by absolute risk reduction equals number needed to treat. So 1 by 0.05, which is approximately 20. Okay, so the number needed to treat in this scenario would have been 20. So if 20 was there in the option, that would have been the correct answer. Okay. If 20 was there in the option, that would have been correct answer. Not sure what was there in the option, but 20, according to my calculation, 20 should have been the answer. Yeah. So one more question was I true heterogeneity in meta-analysis. How do you interpret it? So basically, I squared, which is basically is percentage of variability due to heterogeneity rather than chance. Okay. So as the I square value increases, your heterogeneity is more. So when you have higher heterogeneity, you have to be very careful in that taking or interpreting that data. You might analysis whenever you have that scenario. Okay. So whenever the I square is 0 to 25, it is low heterogeneity. If it is more than 50, then it is, more heterogeneity. More than 75, then it is like very, very heterogeneous. Okay, data. So high heterogeneity means your, data to be like interpreted with caution. Okay. AI role in ICU, role when sole physician present. I don't know what question exactly, but a lot of things can be done. It can help you in, diagnosing sepsis and all correctly, right? It can, with closed loop ventilation, it can help you set ventilator settings. With closed loop drug delivery devices, it can help you adjusting the drug doses and your vasopressor doses and all that. So it can do a lot of things. It can alarm you early, like in hypotension and all of those scenarios. So a lot of things can be done with AI. I don't know what the question was exactly. uh it was, somebody told me that some AI in ICU role when sole physician is present kind of a scenario was given. I'm not sure what was the scenario. So another question is ideal, yeah, data collection and interpretation. Yes, that sepsis. So what AI does best is it can crunch big numbers very easily compared to understanding the nuance or understanding the context, it can actually crunch big number. So, like, what AI is being used in ICU these days is basically for, some closed loop, settings. Like for ventilation, there was a recent trial published for ventilators. It has shown that closed loop ventilators, which basically self adjust their settings based upon patient requirements, are as good as physicians. And those physicians are from a very good place, okay, very good ICU. So if you will compare it with Indian physician or something, you might have like AI is better than Indian physician or something. So AI does few things in ICU. One of those is data crunching. It tells you a lot about, your if your patients are going into hypotension, or if the patient is probably sepsis, because like for Apache 4, Apache 3, you need a lot of number crunching. Apache 2 is used, that is why, right? Because it is easy to calculate. For Apache 3 and 4, you need a lot of number crunching. Apache 3 though didn't become very popular, but yeah. So AI and all can help you with those things, okay? Can help you with those things. Can help you with, telling which patients are at risk, which patients you should be, looking towards, paying more attention towards. So all of those things can it do. Okay.
And don't worry, we are not going to lose our jobs.
Yes, sir. Hopefully, hopefully. I've worked very hard for a very long period of time to lose my job. Yeah. Ideal time to start nutrition in critical patients. So enteral, Espen, Easpen, both within 24 to 48 hours. Parenteral, both after 7 days. If you cannot meet requirements through enteral or oral, then you start parenteral. Okay, so 24 to 48 enteral, parenteral 7 days. Okay, so that is the correct option. VQ mismatch, atelectasis versus PE. So so at electrolysis, you will have low VQ, shunt, right? Which is basically perfusion without ventilation. In pulmonary embolism, you will have high VQ, dead space, right? So ventilation without perfusion, right? So normal is 0.8 to 1, right? Both V and Q are matched in that scenario, in normal scenario. But if you have low ventilation, right, which is in atelectasis with high perfusion, high VQ, right, which is shunt basically, right? So in P, you have high ventilation with low perfusion. So it is dead space. Okay. It is positive. Okay. Okay. So that is there. Okay. A Sir, high altitude pulmonary edema question was there. I don't know what was asked exactly in high altitude pulmonary edema, but few things you have to keep in mind that high altitude pulmonary edema happens when you go in, very high altitudes, like more than 2,500 meters, and or 12,000 feet. But the risk is there after 8,000 feet, but it usually is seen after 12,000 feet. Okay, and it happens because of vasoconstriction. Okay, because of the hypoxia, there is vasoconstriction happening. Some of the areas in your lungs will get severely vasoconstricted compared to other and might leak. Okay, so those areas, because of hypoxia and all, your right heart pressure and all might also increase. You might go into failure and all that also. Okay, so right heart pressure might increase. Okay. So the treatment is basically nifedipine and descent, right? And you have to to prevent it. We basically do gradual ascent, right? Acclimatization, and with for acclimatization, we can take help of acid-zolamide, 125 milligram twice a day. Okay. So that is basically the HAPE understanding. If I don't know what question was asked, so one of these things was there. I don't know. High VQ, high VQ is seen in this. Okay, high VQ is. I think it came back.
Yes.
Yeah. So hepatitis C has no post-exposure prophylaxis available. So only thing what you can do is rigorous hand washing and pray to God that you don't get it, and get yourself tested pre and post after a while. So if it is positive, then you get treated. Otherwise, no need to worry. There is no post-exposure prophylaxis for hepatitis C. Okay, unlike hepatitis B and HIV. Okay, so proper handover technique in ICU. So S bar is the handover technique which is used in, like, you would have read it in ATLS, right? You would have read it, definitely would have read it in ATLS. In emergency, in ICUs, in ATLS, everywhere it is S bar technique, situation background, assessment and recommendations. Okay. So S bar technique is the preferred one. So correct answer was SBAR or S bar technique. Okay. Causal relationship between exposure and outcome, which study designed to prefer? Case control, cohort, or cross section? So for causal relationship, the best uh, studies we have are randomized control trials, right? Because you have a control group, you have a case group, and in the case group, you give the exposure, whatever drug or whatever, and the control group receives placebo, and you get, you know, answer whether this is causing the outcome which you are measuring or not. Okay. If RCT is not there, then cohort can give you ideas, okay, about exposure and outcome. Okay. But case control and cross sections don't. Okay. So here, if RCT was not in the option, then cohort becomes the correct answer here. Okay. Cohort becomes the correct answer here. If RCT is there, then RCT becomes the best answer. Okay. Communication with family, shared decision making in ICU. I don't know what question was there, but there is a value mnemonic whenever you talk about communication skill in the ICU. So read about that value mnemonic, but nothing about, I don't know what question was there, what was asked. I'm not very sure. Okay. So higher MAP target in ICU increases risk of what? There was a trial called, I have taught you also in the classes as well. Uh, So sepsis spam trial was done. Okay. In sepsis spam trial, they compared 65 map with higher map target. Okay. They found mortality was similar in both the target, but in the higher map target group, there were more incidents of uh, atrial fibrillation. Okay, more incidence of atrial fibrillation, and obviously higher inotropic requirement and all of those things were there, because to maintain higher MAP, you need higher inotropes and vasopressors, right? It makes sense. So sepsis palm trial told us that higher MAP target does not improve mortality. That is why the MAP target of 65 came, and it increases the incidence of atrial fibrillation. And I think atrial fibrillation would have been one of the options here, and which would have been the correct answer. Yes, people are saying AF was there. Hope versus S bar, then S bar is the correct answer, I think. Transcutaneous pacing, confirm how to confirm capture. So you will see a pacing spike followed by a wide QRS complex. So electrical with mechanical coupling should be there. Okay. So you are seeing electrical ECG evidence, which is a pacing spike followed by a higher, wider QRS complex. You should also feel a pulse at that point of time. That is electrical mechanical coupling. When only electrical exists, no mechanical, then that means that it is a PEA, right? Pulseless electrical activity. That means that your pacemaker isn't working properly, right? So there should be electrical and mechanical, both should be there. Okay. So I don't know what was in the option, but one of these would have been in the option. Okay. Anaphylaxis after prawn ingestion management is epinephrine, zero point 0.3 to zero point 0.5 mg in anterior lateral, 1 is to 1000 in anterior lateral aspect of thigh. right? That is the correct option. And then you have to give fluids or, ABC you have to do. So all of those things you have to do. Okay. So correct answer is that. So decremental CMAP is seen with. So decremental CMAP, which is common muscle action potential, is always seen with post NMJ pathologies. Okay. Decremental response is seen with post NMJ pathologies like myasthenia gravis. Incremental is seen with pre NMJ like Lambert-Eaton syndrome. Okay. Okay. So this is was one of the questions, I think. Options were what? No spike. How to capture mechanical and electrical, they asked. How to capture means you have to, like, I don't understand. Options were in ECG and increase in heart rate. Yeah, obviously in ECG and both in increase in heart rate should be there. But he's also saying the same thing I said, electrical by ECG and mechanical pulse. So yeah, if that was the option, then that is the correct option. So opportunistic infection, some question was also there. I'm not sure what was the question. So, to revise PCP, at CD4 less than 300, prophylaxis is with trimethoprim sulfamethoxazole, CMV, reactivation in transplant patient, CD4 less than 50, aspergillus, prolonged neutropenia, steroid use, right? So in those patients, candida, broad spectrum antibiotics, central line, immunosuppression, those are the risk factor for candida, right? So I don't know what question was there, but some opportunistic infection and immunocompromised question was asked, I was told. So ECMO versus prone position in ARDS. So proning is preferred and then ECMO. Okay. And proning has shown to reduce mortality. However, ECMO has not. ECMO in Eolia trial, it gives that some in severe ARDS, some benefit of ECMO is seen, right? But in 60-day mortality was not statistically significant. Okay, there was reduction, but not statistically significant reduction, right? So prone positioning, PROSEVA trial has shown us it improves mortality. So proning first, and then if not successful, ECMO. Okay. Agitated patient with raised PCO2, sedation of choice is dexmedetomidine because they have raised PCO2. If you will give any other sedation, they will have respiratory depression, which will increase their PCO2, which will make them acidotic, which may cause myocardial depression and may lead to cardiac arrest. So you have to keep their respiratory drive intact, and the only sedation which keeps respiratory drive intact currently in practice is dexmedetomidine. Okay, dexmed. And this is the last question which I have. Was a long session, two
But
and a
it's
half hours.
it's okay, Manish.
Yeah. But yeah, people are online. 46 of you are here.
Mhm.
Thank you, sir, for the support.
You have done an excellent job, Manish. All right. It's been a long session, but this is very important because there has been, I would say, drastic change compared to the previous year's question paper, and I'm actually kind of happy because they have gone more in favor of critical care. I think
This is
last year,
actual critical care, sir. I mean, I
yeah.
don't think that they have asked medicine here a lot. This is actual critical care only.
This is basic critical
Uh,
care. Okay, these are things which is expected from the students who are giving the exam in critical care. All right.
mm,
So and out of this, I think only about 10 questions we were not able to cover in our online videos. All right.
mm, mm,
Everything
mm.
else we have covered in the Doc Tutorials app video
Yeah.
lessons. Yeah.
I think
So
all of them, I have covered whatever topics I have taught. I think I've covered whatever has come here.
mhm. And I think you have made a summary regarding the areas from which the questions were asked in this paper, right?
Yeah, yeah. I'll just tell you in a
Please
minute.
share
One
that.
second.
And regarding a couple of more questions they have posted here. Patient post arrest, both CVP and arterial pressure is 16 millimeters of mercury cause. This has been, uh, I think this was there, right? Manish, I think you are on mute.
Okay, so I'm sorry. I think so. There are 150 question out of 150 questions. So the I think whatever questions we have, around 146, 147 questions, what we have. So approximately 11 were from ACLS and airway. Mechanical ventilation had around 18. ECMO had 8. Cardiac ECG were 12. Hemodynamics were 9. Anticoagulation was 6. Infection and sepsis were 19. Obstetrics was around 8. Neuro was 6. And others were around 50.
Okay, a lot of questions from antibiotics and from mechanical ventilation also. Okay.
Yes, sir.
Uh, can you please look at the chat?
1 second, sir. Uh, yeah. Electrical, mechanical pulse that we have already discussed. CMV question was probably the opportunistic infection people are saying. So probably depends on what question was there. Uh, Electronic hand washing. So uh, see what I'm not sure what they actually asked with electronic hand washing, but uh, I think it was probably about the fact that less contamination of hand will be there, right? You are touching less surfaces. And there are certain, like in many Indian ICUs also now it is happening. Whenever you, at the entry points, there are automatic dispensers of, like these alcohol solutions, right? So which are electronic. I'm not sure what they ask, but probably there is some data which says that it reduces infection rates or prevents spread of diseases or something. I'm not sure what exactly the question was there. Electronic hand wash is what? Like what question was there? Patient has pulmonary catheter, pressure considered during CPR. I think it would have been LV-EDP, right? End diastolic pressure, because that will correspond to the lower the LV-EDP. I mean, your coronaries get perfused during diastole, right? So your EDP should be basically telling you about what are the chances that your coronaries are getting perfused. It would have been with EDP or something. FENA question, I think we have covered FENA question. There was a scenario where FENA was given as less than 1 and urine sodium was less than 20, and they had asked what was the cause. So this was probably a pre-renal AKI scenario they had given. FENA was less than 1 and urine sodium was less than 20. Mean systemic filling pressure is also, yeah. Oh, okay. So the question was post-arrest after interruption of CPR, both CVP and arterial pressure was showing 16. Oh, okay. Okay. So this is basically equalization of pressure. So what happens is whenever you have, so this would have been a pulmonary embolism or a tamponade scenario. So what happens is when you have very severely dilated right ventricle because of pulmonary very high pulmonary pressures, right? Your right heart pressures will be very increased, and then RV will get dilated and will push the LV. Okay, and the patient develops asystole. So your uh, pressure from the right side will be equal to the pressure, which is CVP basically, which is a like surrogate, right? So your pressure on the right will be equal to the pressure on the left. So that indicates that the patient has equalization of pressure, and that indicates either tamponade or your pulmonary embolism. And the treatment in these patients, they rarely come back without ECMO. So if ECMO was given as the option in CPR, then you should have chosen ECMO. I'm not sure what the question was exactly. I'm just assuming. Question was advantage of electronic hand washing monitors and uh, electronic hand washing monitors advantage. They can tell you so it has been seen the higher the units which have higher hand washing rates, lower, hospital acquired HAIs rate. Okay. So you basically want to target higher hand washing rates for your units. So either it was related to that these monitors might help you in monitor your hand washing rates of your unit, which reduce the HAI rates, or something related to that. I don't know what were given in the options. Yeah, mean systemic filling pressure. It indicates what? That 16. Oh yeah, that also will indicate mean systemic filling pressure. Yes. I, I don't know what the question is. I still don't know what the question is. I don't know, sir. I mean, I think I'm not getting it. Two, three questions I think we have not gotten.
Then one doubt is whether in VAP MRSA linezolid or vancomycin, as linezolid has better lung
Yeah,
penetration. Means,
linezolid
uh,
is preferred. Daptomycin is not used whenever it comes to lung. So daptomycin, if it's an option, it would have been the odd one out. Uh, and if you are choosing between Vanco and linezolid, then linezolid is preferred because linezolid has better lung penetration.
yes. One question is maximum correct answer for rank one. What's your opinion,
Sir,
Manish?
I think considering this, so I think somewhere around 250 to 280 should be uh, top ranks, like maybe 290, 300 maximum, I think. Because, like, although paper was not very difficult, but I've been told that it was lengthy because there were scenarios after scenarios, and you have 1 minute per question essentially, right? So I'm assuming it last year it was around 280, and the paper was comparatively less complicated than this. So I'm assuming slightly lower, maybe, but I'm not very sure.
This is something which all students said that the questions were very lengthy.
Mm,
But this is something which we predicted also last year itself,
mm. Yeah,
because
yeah.
last year the examiners didn't have much time to prepare. All
Mm,
the questions were sort of like just in phrases or
mhm.
straightforward one word answers you would get. This is something which we have to expect next year also. It's going to be just like this. But the questions are relatively straightforward. These are basic topics in critical care, which everyone is expected to learn.
Yeah,
Right. All these things we have already covered in our lectures. So, um, I think if you had gone through the lectures, if you have read the ICU book on Paul Marino or Washington Manual in Critical Care, it should be good enough to answer most of these questions.
yeah. I think, yes, sir. Most of this is like, obviously some will always be out of the syllabus.
Hmm.
Even what we cover, it won't be from there. but most question, the target is to get maximum correct, not all correct, because all correct is never possible. Even for me, sometimes I will get something wrong. Like you will also probably get something sometimes wrong, but that is normal human nature. So that is all right. But try to get maximum correct. So for maximum, you have to follow, do solve more questions. And with passage of time, we are also figuring out and improving the question paper based upon our MCQs based upon these. I think a lot of our MCQs were around this only, but not exactly. So let's see.
Yeah. So when you guys are watching the recall video, this recall video in the app, please check the chat box also, because a
Hmm.
lot of students have put in the questions the right options also, which we were not able to collect. So
Hmm.
please check the chat box also, and I would like to thank all the students who have participated in this chat. All right. So I think with that we can wind up the session, Manish. Excellent job. Thank you so much, Manish. And once again, thanking all the students who contributed the questions for making this session. All right.
Thank you, sir. Thank you,
Thank you, Manish.
everybody.
Thank you, everyone, for joining. Have a good night and have a wonderful 2026.
Yeah, thank you, sir. Same to you.